Prevention isn't sexy, but 21st century healthcare depends on it. Over the course of my GP career so far, I've had to send a number of patients to the hospital for acute illnesses and acute treatments. And it isn't a hyperbole to suggest that we may have saved some lives along the process. Modern medicine is fantastic at drawing people away from the edge of illness, but it's surprisingly terrible at preventing ill health in the first place. We celebrate cures, we applaud rescues. But what is the greatest achievement in modern medicine of them all? That is the illness that never happened. As a GP, I'm used to seeing patients every 10 to 15 minutes, and I'll do what all of my other colleagues do. I'll take a history, I'll examine, I'll order some investigations, maybe prescribe a treatment, and I may have to refer a patient to a specialist to be seen either on the same day, as a routine referral, or even to rule out the possibility of there being cancer. But how many of those patients do you think come back to me week after week, month after month, year after year, having never really got to the true reason why their illness presented in the first place? And maybe a progression of their condition, a worsening of their health outcomes, or even a side effect of their treatment. It is surprisingly common. 80% of heart disease, strokes, and type 2 diabetes are preventable through lifestyle and environmental factors. And sadly, every year on average, 100,000 people in the UK will go on to have a heart attack. That means over the course of this roughly 15-minute talk that I give you, 3 people on average will have had a heart attack in the UK. And 70% of healthcare spending on the NHS is done to try and treat things like heart disease, frailty, COPD, and strokes. And ladies and gentlemen, did you know that there is something that we can do, something that does not cost a penny, not even a medication, that we can do to try and prevent worsening of heart disease? That medicine is movement, ladies and gentlemen. Movement can actually reduce your risk of heart disease by up to 30%. Now, if I get a show of hands, how many of you do exercise? And keep your hands raised if you exercise on average 2.5 hours every single week. Good, fantastic. So if you do, that level is what the guidance recommends to reduce the heart attack risk by 30%. What it also does is it also reduces your cortisol levels. Now, we heard about cortisol a little bit earlier on. For those of you who don't know, cortisol is a stress hormone. And by reducing cortisol levels, we reduce stress, we improve our mental health, and we also improve our cognition. But actually, one of the reasons why we don't talk about some of our major achievements, so for example, we don't talk about the heart attacks that never happened, we don't talk about the strokes that we prevented, and we don't talk about the blood pressures that we reduced. And that's because those successes are silent. We don't ever hear about them. I'm now going to talk about a few conditions that I see commonly as a GP. The first one is diabetes. Many of you will know about diabetes. It's a condition whereby the body is unable to process blood sugar and reduce the levels appropriately. And it can cause problems with the heart, the brain, the kidneys, and the eyes, amongst many other things. But actually, did you know that there is also a condition called prediabetes? Now, prediabetes was a term coined in the 1970s/80s, where we started to recognize that there is a cohort of people that are at risk of developing diabetes, on the borderline, but don't quite reach the diabetic levels. And why does that matter? Well, every year, 5 to 10% of patients with prediabetes will go on to develop diabetes. And across their lifetime, 70% of pre-diabetic patients will go on to develop diabetes. And again, well, why does that matter? Well, if you think about it, you want to think about the wider economic impact. If the patient isn't able to live a successful life, they may not be able to work. They may not be able to have good mental health as a result. And just a practical thing, such as the cost of prescribing medications. But again, we can do something about it without prescribing a single medication. So the NHS came up with the National Diabetes Prevention Programme, which is a 9-month intensive programme, either face-to-face, virtual, in groups or one-to-one, where patients are invited to join, and they can then have intensive diet advice, lifestyle advice, exercise advice, and actually works towards changing their behaviours. And this has been found to be a very cost-effective measure of preventing these patients who are pre-diabetes from going into the red and becoming diabetic. When we think about physical health, it's really easy to be aware of. But as we've talked about over the course of this evening, we should also think about mental health. Because, ladies and gentlemen, did you know that patients with severe mental health illness are likely to die 15 to 20 years younger than those patients without a severe mental illness? And of the physical health illnesses that they suffer from, we can actually prevent 2 in 3 of them. That's quite staggering, isn't it? And when we think about the physical health and the mental health of these patients, they are rarely in silo. They come as part of a package. And that package is their socio-economic status. So we have to think about their employment situation, their housing situation, even their family situation. How many of these patients do you think also suffer from chronic loneliness? Probably quite a lot. And we know that multimorbidity, so having more than one health condition, can affect people in more deprived populations 10 to 15 years earlier than those from affluent populations. So by being able to tackle this at an earlier stage, we can also do something to reduce health inequalities, which is not just unique to the UK, but across the world. As mentioned, for now, I'm the clinical lead for Frailty in my local integrated care board, who are the commissioners for healthcare services in my area. And I'm just going to share a few examples of what we're trying to do to try and prevent patients who are frail from becoming even further frail. For those of you who've gone to medical school, you are often taught about prescribing. So what the medication is, what the dose is, what the side effects are, and maybe some interactions with other medications. But are we taught enough about de-prescribing and maybe the harm that our medicines can cause? Because the more medicines that an older adult is on, the more likely they are to fall. And falling is one of the worst things that can happen to an older adult, because you are more likely to fall again after you've had that first fall, and you're more likely to decondition as a result. So de-prescribing is something that's really important to us as a team. But if that patient was to fall, and unfortunately that can happen, what we have to do is try and prevent that next fall. Okay? So we have a service called the Early Intervention Vehicle Service. And so what that is if a patient has fallen, rather than an ambulance being called, assuming that the patient is well enough to stay at home and end up in A&E, the early intervention vehicle will come out to see the patient and they'll do a rapid assessment, make sure that they are safe to be at home, and they might initiate various different strategies. So, for example, they might get physiotherapy involved. They might even be able to suggest some equipment that might be suitable for the patient to prevent them from falling again. Or they might liaise with social care to try and get them a package of care. Because, ladies and gentlemen, I'm sure many of you have been in an A&E in the winter in the UK. And you'll see how stretched, with the best intention in the world of my colleagues in A&E, they are stretched. And we often see patients in trolleys, older adults who maybe haven't been fed, they haven't had enough to drink, they haven't got out of the trolley for many hours waiting to be seen, and they may not have even had their medications. And so we know statistically that the moment that an older adult ends up in A&E in a trolley, they are more likely to decondition as a result. So delivering care closer to home is not just an ideal, it is an absolute necessity. I'm going to share an example of a piece of work that myself and my colleagues were involved in a couple of years ago. We completed an integrated care fellowship. And integrated care is this idea whereby healthcare work alongside organisations such as mental health, social care, as well as the community and voluntary sector organisations. And we were asked to do a project around frailty. My colleagues and I recognise that the importance of pre-frailty, so i.e. how we can prevent people from becoming frail in the first place. And so what we set up was a one-stop shop, as you can sort of see, whereby pre-frail older adults were invited to come, and we had all the relevant stakeholders in one place at one time. So we had a nurse, being able to do blood pressure checks, making sure that their blood pressure doesn't drop when they stand up as well. Because if you stand up and your blood pressure drops, you're more likely to fall. Doing things like a height and weight. And even a really cost-effective measure to prevent older adults from developing respiratory illnesses and end up in hospital, a flu jab. We had a pharmacist doing the medication reviews and making sure that the medications were appropriate and we weren't prescribing causing harm. But we also had members, as you can see in the back there, members of the charity organisations such as educator, the service that do Meals on Wheels, and even Citizens Advice Bureau. And actually, there is a professional that sits in between both of us. That professional is called a social prescriber. And what a social prescriber does is it provides brief interventions for older adults, or adults generally. What they can do is they can signpost patients to advice on things like employment support, benefit support, even something as simple as where's my nearest exercise class that I can access in my local area. Because, ladies and gentlemen, what I've realized as a GP is that sometimes the best prescriptions that we can give are not medical. They are social. This is us as a team. I'm going to share an example of a gentleman called John. John's not his real name, but he came to our event in Cambridge a couple of years ago. John was quite cynical about the healthcare system. He was an ex-veteran who served in Northern Ireland in the 1970s, 1980s. Sadly, he was witness to a bomb explosion, and even more sad than that, a child's body exploded in his face. He suffered flashbacks ever since that day. He suffered from post-traumatic stress disorder, and he had even contemplated suicide. He came to our event feeling quite cynical, not really knowing what to expect from our event, but he gave us a chance. And when he came, he was able to share with us how he had found so many different things that were available for him to support him through what he had been going through. And he was overwhelmed with the support that he had received. John is just one example, but there are many other people like John. He was just the most memorable, if I'm honest with you. But there are so many other people who benefited in a similar way to what John did. And what I hope is that someone like John and the people that came are able to now be able to live more productive and more fulfilling older life. And the NHS has started to recognise that. And so as part of its 10-year health plan, it has started to develop what we call neighbourhood services, where we bring together healthcare, community specialists, mental health, social care, and the community and voluntary sector organisations in one place, in one time, to try and deliver better care closer to home. So you would think that with all that I've said so far, that healthcare spending on preventative health would be really optimal. Wrong. If you can see the numbers, those numbers is the average that OECD countries spend on healthcare spending on prevention, about 3%. If you look at the white bar, you will see that in 2021, healthcare spending on prevention did go up. But that was as a result of COVID and the vaccinations, which counts as part of preventative health. But then if you look at the light blue line, 2023, you will see it went straight back down. And to use a fire analogy, it is like spending 97% of your spending on fires, putting out the fires, and only 3% on fitting smoke alarms. So think about that. Going forward, what could the role of AI have in terms of preventive health? Again, a show of hands, how many of you are wearing a smartwatch? Good. So for those of you who are wearing a smartwatch, you will probably have a pulse checker on one of the apps. Now, a pulse checker can identify whether or not your heart is beating regularly or irregularly. If it is beating irregularly, it might pop up as an alert. And that could suggest a condition called atrial fibrillation. Atrial fibrillation is a condition where the heart doesn't beat regularly. And as a result, if your heart doesn't beat regularly, your blood can start to go sticky. It can form clots. And if those clots go to the brain, it can cause a stroke. And this is something that's preventable through medication, but we need to identify it. So by identifying it, we can actually make a huge difference to patients' quality of life by them not having a stroke. There is even really clever technology where you can use a photo of the back of your eye to identify your risk of having a heart attack. From a wider system level, We can also use the information that we have, the data that we have, to identify which areas of population in our neighborhoods have high levels of deprivation and potentially might have lower vaccination rates, poorer prescribing, higher rates of painkiller prescribing, for example. And so we can use that data to help us understand where we can target our populations. And on a practical level as a GP, I can use AI to help me to type my notes out when I'm consulting with a patient. It just listens to my consultation and types it out for me. It can automate the process of actioning normal blood test results and even prescribing where there are no potential risks or no potential queries. All of these things can help me to do the job that I want to do the most, which is being able to talk to patients and trying my best to prevent ill health from happening. And so as I reflect on my career so far, I would like to share my final thoughts with you all. The moments that change lives are rarely dramatic. The conversations that I had are often quite mundane, but those quiet conversations may lead to behavior change. My colleagues and I would never expect a round of applause because those moments are silent, and they're us just doing our jobs. Prescribing a tablet can only take seconds, but the greatest difference that we can make in modern medicine is not by extending life by a pill that we prescribe. It is adding quality years of life to prevent an illness that never arrived. Thank you very much.